We're going to spend the next few minutes talking about adolescent medicine and sexual health. And throughout this talk and my other talks, what I'm going to try to do is to say as often as I can, know this for the boards. This is a particularly high yield topic for the boards in the hopes that that will help you better prepare. If you look at the certifying exam content domain, about 5% of your exam will be adolescent medicine topics, and another 7% will be infectious disease. And you get infectious disease in at least 3 talks this week. Obviously, the extended infectious disease talk that Dr. Bolton is going to do. We're going to cover sexually transmitted infections in adolescent medicine, and we'll cover upper respiratory infections later this afternoon. So this makes up probably at least 8% if you just look at this morning's topic of your board certifying exam content domain. So this is what we'll be reviewing over the next few minutes. So let's get going and talk very briefly about these 3 topics at hand. Keep in mind in a board question that oftentimes the presenting complaint will not be what the particular individual is really concerned about. So the headache and fatigue may actually relate to the fact that the individual is presenting with a history of domestic violence or a history of sexual abuse. So you'll need to read the question carefully for hints like this. So an adolescent presents to the emergency department with a chief complaint of headache, but then as you read the scenario, you learn that she maintains no eye contact, looks downward, and appears either frightened or depressed. So keep that in mind. The chief complaint is not always what the actual patient is concerned about, and it may not be what the board question is asking you about. On the exam, if there's an opportunity, if there's an answer option that includes preventive counseling or addressing health maintenance needs and immunizing, then that's almost always going to be the correct choice. So let's start with this audience response. Which one of the following is the leading cause of mortality in the older adolescent age group? Homicide, suicide, malignancy, unintentional injuries, or accidental overdose? Good. And so the majority unintentional injury, and that's correct. And one thing to keep in mind is if you are asked about this question, here are the top 5 causes of both morbidity and mortality. And when you look at the causes of the number 1 cause, unintentional injury, they're listed here, with motor vehicle accidents being the most common cause of both morbidity and mortality in this particular age group. And as with all unintentional injuries, more common among males than females. So if you're asked a question like this, they'll describe an adolescent. They won't tell you the adolescent's age, but they'll describe certain characteristics about that adolescent and then ask you, is this adolescent an early adolescent, mid-adolescence, or late adolescence? So the purpose of these next 3 slides is just to try to give you some cues that would help you to differentiate the stage at which that adolescent is in. So for example, cognition is concrete, preoccupation with self, poor impulse control, all cues that you might read that would help you understand that this individual is on the younger side of adolescence. Versus mid-adolescence, where the feelings of omnipotence and immortality really begin to set in. Peers become the most important group. cognition to some degree begins to develop, and the like. And then finally, the more idealistic outlook on the part of someone in late adolescence, where individual relationships become more important. And again, the scenario on the boards would be to use some of these descriptive terms and then ask you where that particular adolescent is in his or her development. Now, in regards to the American Board of Pediatrics, they have a lot of very specific recommendations in regards to confidentiality. And that is, in almost all cases, that confidentiality should be ensured, and also to do all that you can to encourage adolescents to involve their family in the various medical decisions that they have come to seek your care for. But keep in mind, if parental notification is likely to impede the adolescent in seeking necessary treatment, then the board recommends that confidentiality be maintained if at all possible, and then treat without parental consent. Now, the boards love exceptions, and there are obviously some exceptions to this, and those exceptions will be listed in a second. But why do we encourage confidentiality during an adolescent visit? It certainly grants them more control, encourages them perhaps to seek more timely care, provides for a more candid, open discussion, and may, in many cases, especially if they have chosen behavioral habits or lifestyle that the parents are disagreeing with, it will protect the adolescent from the potential of humiliation or discrimination. So know your state laws, because they will differ. But here are the exceptions. Mandatory disclosure and breaking confidentiality is recommended by the board when there's physical or sexual abuse concern, serious risk of harm to self or others, and non-compliance with the treatment of a serious disease. In some states, and again, you need to know your state laws, parental consent for state-funded contraceptives and family planning and women's health services is required, but this is in the minority of states. So when there's a difference between state laws, you're not going to be asked that on your boards. So you more likely would be asked about these three first bullets than you would be about something that differs from state to state. Now, you do need to know the definition of an emancipated minor, and that is a minor who can attain legal authority prior to reaching, in most states, 18 years of age. And you can do that by marriage. You can do that by military service. Again, the board sometimes asks you about rare things, sometimes asks you about rare diseases, and I don't think there's anything more rare than an adolescent living separately from parents and managing their own finances. I've never heard that. And if any of you have heard that, please see me, because it's just, I think, unattainable. So keep in mind that this relieves the minor's parents from any legal liability. So know for your boards that this age is typically 18 or above, with the exceptions being that if the individual meets the definition of an emancipated minor. Now, the typical rights include these in terms of self-consent, treatment of STIs, seeking help for the variety of issues such as pregnancy, prenatal care, and the like. But certainly the take-home message over the last couple of slides is if the law differs from state to state, you will not be asked about it on your boards. If it's similar in regards to overarching board recommendations, for example, when to break confidentiality, that's fair game for your boards. Okay, what about testing for drugs of abuse? Very clearly, the Academy does not endorse home drug testing, and advises very strongly against involuntary drug testing of adolescents, and goes further to say that testing should not be done without the adolescent's knowledge or will, with the exception of a couple of specific cases. So here's the exceptions. When might involuntary testing be appropriate? Typically, involuntary testing is going to be the incorrect answer, but on certain occasions it will be the correct answer. Following an accident or suicide attempt, for an example, an unexplained seizure, assessment during a health maintenance visit that raises concern about fatigue, moodiness, school failure, change in behavior, change in peers, loss of friends, lack of interest in sports when the individual was previously interested in sports, for example. When an individual is in a drug treatment program, then certainly it's appropriate to drug test that individual. And if there are findings on physical exam that are strongly suggestive of substance abuse. But again, even in those categories, it is far better to test with the adolescent's knowledge than without the adolescent's knowledge. And problem drug use is much more likely to be detected not by random drug screens, but rather by a careful evaluation during a health maintenance visit, again, ideally involving the family. And if a parent asks you, why can't you drug test my son or my daughter? There are various topics to discuss that will hopefully enable you to come to a legitimate conclusion that both of you agree with. So why is it necessary? What are you going to do with the results? And think about what you'll do before you get them, whether they're positive or whether they're negative. And also be sure that parents understand that drug testing may or may not accurately reflect what the individual is or is not practicing. So the board scenario that gives you the option to move directly to drug testing without having some of the topics covered during a conversation that are listed here is the incorrect answer. Always choose more discussion, always choose less testing versus less discussion, more testing, et cetera. In general, that's a good rule to keep in mind for any board test. Okay, so let's move on to specific screening recommendations that you might be asked about. This is a nice mnemonic that you might want to keep in mind as you put together various topics that you're going to be talking about with your adolescent patients, as well as topics that might come up on the boards. So, screen for depression at every visit between 11 and 21 years of age. And that risk assessment will typically be one of the many depression screens that are available online. And also that risk assessment should include a careful family history for parental depression or depression among older siblings, and very importantly, a screen for associated comorbidities. And we'll talk about this in more detail in a couple of days when we do behavioral pediatrics and talk in detail about substance abuse. But remember, a relatively recent recommendation is annual screening between these ages. Screening for eating disorders is also recommended, and there are two very short question bases that are currently recommended. The SCOFF 5-question series that is here, and keep in mind that answering yes to 2 or more of these questions should prompt additional evaluation for an eating disorder. A second relatively common screen is listed here, and again, if there are more than or equal to or more than 2 concerning responses or abnormal responses, then that individual should be additionally evaluated for eating disorders. And in a couple of minutes, we'll be looking in more detail at the eating disorders, how to evaluate those particular individuals. Now, other screening recommendations that you should be aware of. BMI should be screened at least yearly. Here are the definitions that you should know, and you do need to know the difference between overweight and obese, because once you're given a BMI, your response to the next best step in the treatment of this individual will differ, and we'll look at how that differs in just a second. Unfortunately, as you well know, the rates of obesity have more than doubled in children, tripled in adolescents, and now over a third of adolescents are either overweight or obese. Risk factors include obesity at a younger age, African American girls, Mexican American boys, and prenatal risk factors are also present, including increased weight gain during pregnancy, high birth weight, and a history of gestational diabetes. Now, intervention is recommended when the percentile is greater than or equal to the 85th percentile, but the intervention differs, as I said earlier, in regard to whether the child is considered obese or overweight. If they are considered overweight, then the next best step answer is to encourage that individual to maintain weight. If they are obese, the next best step answer is to encourage that individual to lose 1 to 2 pounds a week. So that's why you need to be careful to know the difference of the BMI definition of obesity and the BMI definition of being overweight. And then reduction of energy-dense foods, saturated fats, trans fats, cholesterol. In other words, dietary changes are always going to be recommended. Whether you recommend those in an attempt to lose weight or recommend those in an attempt to just maintain weight, again, will differ based on the information that you're given. Blood pressure should be screened annually throughout adolescence, and keep in mind that the diagnosis of hypertension must be confirmed on 3 repeated and separate visits. And in adolescents especially, because there's a lot with a history of white coat hypertension or even some anxiety when checking their own blood pressure at home, a 24-hour ambulatory blood pressure monitoring may actually be the best way to get an accurate description of blood pressure. And I would say if you're given that option prior to initiating therapy, even if they describe 3 elevated blood pressures, I would choose the option of 24-hour ambulatory blood pressure monitoring over treatment if you're presented with that particular scenario on your boards. The term elevated blood pressure was replaced in 2017 by, elevated blood pressure has replaced the term pre-hypertension. You can see the definitions here, but this is a relatively recent change, but I do think that it is probably old enough so that it will likely appear on your boards, and you'll see the term elevated blood pressure rather than pre-hypertension. Vision should be screened yearly in regards to assessing one's vision, and then formal visual acuity screening is recommended now by the AAP only twice, and that's at 12 and 15 years of age. They may ask you, when do you refer a patient after you have checked his or her hearing, and the referral criteria are listed there for you. Hearing is a little bit different. Risk assessment yearly, but no formal testing is recommended every year, but only during the early part of adolescence, the mid part of adolescence, and the late part of adolescence, one time in each of those 3 periods of age. During anticipatory guidance, one should recommend that earbuds be used for no more than an hour at no more than 60% maximum volume, And mild hearing loss is defined for you there. And keep in mind that even mild hearing loss can lead to problems with speech perception. How about screening for cervical cancer in the adolescent population? Know that the risk for cervical cancer is in some ways dependent upon ethnicity, socioeconomic status, the immunocompetent or immunosuppressed individual, and the time at which the individual woman first delivered a child, or if she has had multiple births. Also, the earlier the onset of sexual activity, the more likely the risk for cervical cancer. As you might expect, the younger the age, the more concern there should be about the potential risk for cervical cancer. And obviously, it is also associated with the number of partners that the young woman has had. And if those partners themselves practice high-risk sexual behavior or have a history of STIs. That being said, remember also that HPV is central to the development of cervical neoplasia, and HPV is the most common STI in the United States. There are many types, and this is one case where I think you might want to know serotypes. And if you think of pneumococcal, for example, there are 40, 50, 60 different serotypes. You'll never be asked about those. But I think it's potentially possible, probably a fair question, if you were to be asked about the HPV serotypes that most oftentimes cause genital warts, 6 and 11, and cervical cancers, 16 and 18. So that's why those are bolded there for you. Now, the HPV vaccine, the only one that is currently in use is the 9-valent HPV vaccine, and it's licensed for both young men and young women between the ages of 9 and 26. Those age groups are important to keep in mind. We'll talk about that in a second. And again, the older 4-valent and 2-valent vaccines are no longer in use. The recommendations relatively recently changed, and those recommendations now state that only 2 doses are required, and this is at 11 to 12 years of age. And for catch-up, you can continue to give only 2 doses in those under 15 years of age, but once they reach 15 years of age and above, a 3-dose series is then required. So if you're asked in a question in regards to how best to immunize with this vaccine, carefully look at 2 things. How many previous vaccines did they receive, and at what age did they receive those vaccines? Because it may be that you need a total of 2 or need a total of 3. Catch-up vaccination is recommended a little bit differently. It's recommended up to 26 years of age in young women and up to 21 years of age in men. And it is currently recommended specifically only in older men, in this case between 22 and 26, if their sexual practices put them at higher risk of HPV, or if they're immunocompromised. Otherwise, permissive use is recommended. So in other words, a 24-year-old male without these particular risk factors, it's up to you in regards to whether you choose to catch them up or not. But remember the relatively recent change in the number of doses required depending upon the age of the individual. Also, keep in mind that any child who has been sexually abused should be immunized with the HPV vaccine if he or she is 9 years of age. And also keep in mind that if the individual is immunocompromised, that individual should begin his or her vaccination at 9 years of age and does require a 3-dose series even though they are under 15, and that is because of their immunocompromised status. It is not recommended in pregnancy, although there's no evidence of harm, and pregnancy testing is not recommended prior to vaccination. Another question you might get is a young woman who presents with a history of HPV. And they might ask you, is HPV vaccine indicated in this case? And it absolutely is, because again, there's 9 serotypes in the vaccine. It's highly, highly unlikely that that individual woman has been infected by all 9 serotypes. So that is not a contraindication to the HPV vaccine. Okay, question 2. In which one of the following immunocompetent patients is a pap smear recommended? An 18-year-old with 3 lifetime sexual partners, a 19-year-old who is choosing to initiate oral contraceptives, a 17-year-old with 2 lifetime partners who has not received the HPV vaccine, a 21-year-old with a lifetime partner, and an 18-year-old with a sexual partner recently diagnosed with an STI. Which one of these is a pap smear recommended? Terrific. Okay. So first pap smear, 21 years of age, regardless of sexual history. And that's important to keep in mind. So begin cervical screening at 21 years of age in immunocompetent asymptomatic women, regardless of the age of initiation of sexual activity, and that PAP needs to be repeated every 3 years. Screen even if sexual abstinence is reported. Now, why wait? Well, about 90% plus of cellular changes in adolescents will revert to normal and therefore spontaneously clear their HPV infection and any associated abnormalities. So there is a very low incidence of cervical cancer. Many of those cellular changes revert to normal. Cervical cancers are slow growing, and this more cautious approach avoids harm from unnecessary intervention. For example, colposcopy, leading to an incompetent cervix, leading to difficulty carrying a pregnancy to term later in life. And co-testing with PAP and HPV is not recommended. That is only recommended typically around 30 years of age. And again, co-testing, not recommended. That's your answer for your boards. All right, now the exception. Again, exceptions are all over your boards. If the individual is immunocompromised and immunocompromised due to HIV infection, then at the time of diagnosis, it is recommended that a PAP be obtained. There's not currently any consensus in regards to PAP and HPV testing, so you're not going to be asked about that, but you will be asked about whether or not to obtain a PAP smear in someone at the time of diagnosis of HIV infection. If the results are normal, most sources say to repeat it in a year, and then only after 3 consecutive normal doses can you revert to a pap smear every 3 years. And any abnormal result, again, because of their immunocompromised status, should be referred for colposcopy. If they are immunosuppressed by some other disorder other than HIV, unfortunately, the recommendations vary. But then again, for your boards, when recommendations vary, you won't be asked about it. So if you're asked about when to do an earlier PAP, it will likely be related to a young woman at the time of her diagnosis with HIV. All right, third question. A 19-year-old male is diagnosed with and treated appropriately for gonorrhea. He was treated in a manner that you know that the treatment was indeed taken and completed. When should he be retested? a week, 2 weeks, a month, not indicated, or 3 months. Good. So 3 months is the correct answer, and two things to keep in mind about this. One is that test of cure is not indicated. So in other words, testing soon after completion of treatment to make sure the infection is resolved is not recommended. But retesting is recommended in 3 months because there is a high prevalence of both chlamydia and gonorrheal infections after recent treatment, and that high prevalence represents reinfection rather than treatment failure. Therefore, retest for reinfection in 3 months, and there is not a test of cure that is recommended. Screening recommendations in part relate to STI risk factors that you need to be aware of. And so risk for STI, again, includes younger age, who has chosen to become sexually active, obviously a previous history of STIs, multiple partners, inconsistent use of birth control, especially condoms, those who are in commercial sex work or homeless and performing sexual favors to survive on the streets, and those who might be involved with illicit drug use. So the screening recommendations for chlamydia and gonorrhea are as follows, and they differ slightly between women and men. For women, annual screening for both is recommended in any sexually active woman in the adolescent age group. Why is that? Asymptomatic infections are extraordinarily common, and serious complications will occur if they are untreated, such as PID, subsequent infertility, and the like. Although vaginal swabs in the literature are preferred, certainly in the real world, urine is obtained to test for a nucleic acid amplification test, NAAT, to look for the presence of infection due to gonorrhea or chlamydia. So all sexually active women in the adolescent age group recommended to screen annually. Now, what about males? At least from a board perspective, it is different in the fact that annual screening is not recommended, and screening is only recommended among males with a history of an STI or those who present seeking STI evaluation or in areas of high prevalence. Again, I think in the real world, many of us may be working in communities or at centers where there is indeed a high prevalence, so you are screening males once a year as you do females. But for your boards, know that there is a difference in regards to the recommendations between men and women. Now, screening is not recommended for a variety of other STIs in otherwise asymptomatic, lower risk adolescents. So all of these STIs, no recommendations for routine screening. For HIV, all adolescents should be tested at least once unless the prevalence in the community is less than 0.1%, which would be a very rare, I think, prevalence. And HIV screening, again, here's an exception, should be at least annual, if not more frequent, in those with high-risk sexual behaviors that are listed here. So everyone, one time, high risk annually at least for HIV screening. HIV screening and HIV infections are going to be discussed in much more detail in the ID lecture, so I will not talk about testing any further. Now, what are the screening recommendations in men who have sex with men? They are more comprehensive. Annual screens with HIV, with syphilis. Again, here are the exceptions. A couple slides ago, I said don't screen for syphilis. Here are the exceptions that boards like to ask about. So syphilis and chlamydia and gonorrhea genital infection, and depending upon their sexual practices, rectal and or oropharyngeal infection. At least annually. Some sources say every 3 to 6 months if there are multiple, and especially if there are anonymous partners. Again, I don't think your board is going to give you the choice, 3 months, 6 months, 12 months. Because again, when there's variability among practitioners and there are not specific guidelines, they're not going to ask you about that. But the take-home message here is much more frequent screening amongst individuals with these high-risk sexual practices for HIV infection and other STIs. Also, it is recommended that men who have sex with men be screened for hepatitis A and for hepatitis B, and always choose immunize as the option of choice if they indeed do not show evidence of immunity to either Hep A or Hep B. Hepatitis C should be screened at least once, and ongoing screening is recommended to detect infection in those who are HIV infected and who practice high-risk behaviors. So lots more screening in this population of individuals. Know also that you might be asked about disorders that are due to receptive anal intercourse or disorders that are due to sexual abuse. And there's a difference between proctitis, which involves inflammation which is limited to the distal portion of the rectum, and proctocolitis, which is inflammation of the colonic mucosa. Proctocolitis presents with individuals who are more seriously ill, and the pathogens between the two disorders do vary somewhat. Again, we'll be talking more about STIs later this morning, but know that the treatment for these disorders is doxycycline and ceftriaxone. And there'll be, I suspect, a fair number of questions on your boards about treatment protocols and treatment options for STIs, as well as, I'm sure, all the other infectious diseases. Now, in regards to women who have sex with women, the same screening recommendations hold as for the general female population. The risk of STIs will vary depending upon their sexual practices and depending upon the number of partners. And although there is some evidence to suggest that there is a higher risk of bacterial vaginosis, at this time there's no data to support routine screening for bacterial vaginosis among this population of women. All right, moving on to something different, hemoglobin, hematocrit, and urine screening. In the adolescent, assess risk and screen as indicated. In other words, there is no time during adolescence, in fact, there's no time during pediatrics where a routine hemoglobin and hematocrit is recommended, except perhaps at year 1 and in some states year 2. So if the adolescent has a history that suggests that he or she is at greater risk of anemia, some of the risk factors are listed here, then the answer is screen, but the answer is no routine screening in the adolescent population in the absence of these risk factors, and urinalysis screening is never recommended. All right, question 4 to cholesterol screening. When is routine non-fasting cholesterol screening recommended? At 11 to 12 years of age, 11 to 12 and repeated every other year in those at risk, at 15 to 16, twice D during the adolescent years, or yearly only in high-risk patients beginning at 11 years of age. So routine, non-fasting cholesterol screening. Good. All right, so exactly. So 2 times for all populations, regardless of risk factors. So let's look at that a little bit more closely. So what are the definitions? If you're going to screen and you're going to be given results on your boards, you should know the cutoffs between acceptable levels, borderline levels, and high levels. So they're listed for you here. And then again, universal screening with non-fasting lipid screening using non-HDL-C levels twice during adolescence, 9 and 11, and again at 17 to 21 years of age. Now, what do you do with the results? This is why you need to be familiar with this slide. If the results show values that are listed here, in other words, somewhat elevated, then you need to retest in 1 year and implement dietary and lifestyle changes. So to get these questions right on your boards, you'll have to know the definitions and you'll have to know the point at which intervention is recommended and then what that intervention should be. So repeat testing in a year at these levels, and if the levels are higher, then the next best step is to obtain 2, in this case, fasting lipid profiles and average the values. And those lipid profiles should be obtained at least 2 weeks apart and no more than 3 months apart. So know the values, because the answer to the next best step in the evaluation and treatment of this patient will vary depending upon what those particular values are. For the results, this is the next step. So now that I've gotten 2 fasting lipid panels, now what do I do with the results? And the answer to that is here. Obviously, dietary changes and evaluating for secondary causes, some question about pharmacotherapy and referral to a lipid specialist. I would suggest that on the general pediatric boards, the answer is lipid specialist, not for the general pediatrician to institute statin therapy, okay, for the boards. And no doubt that referral is indicated with higher levels. So the step-by-step approach to the best next step in the treatment of this patient is going to depend upon age, risk factors, and the values that you get in regards to your testing. All right, are there individuals between the ages of 11 to 12 and 17 to 21 that should be tested? Again, here's an exception, so you're going to need to know it. So you should screen, and in this case with fasting lipid panels, between 12 and 16 years of age with a positive and concerning family history, be it earlier cardiovascular disease or a parent with high cholesterol, or if the patient, him or herself, has these particular risk factors. If the screen is abnormal, then again, it needs to be repeated and the results averaged. So these are the individuals outside those recommended age groups for routine screening that should be screened. All right, what about tuberculosis in terms of screening? Annual risk assessment throughout adolescence is important, and targeted testing rather than routine testing is recommended. And targeted testing can be either with skin testing or with IGRA, interferon gamma release assay. And you can see the various high-risk criteria that are listed here. Now, what makes a skin test positive? I've seen this question a lot on various step exams, shelf exams, board exams, recertification exams. They'll give you a TST result, and then they'll ask you, what do you do? And so you've got to look at the description in the vignette that identifies how high risk or low risk this particular individual is. So in duration of greater than or equal to 5 is considered positive in those with evidence of TB or close contact with another individual with TB, or in the most likely cases, if that individual is immunocompromised. In duration of 10 is considered positive in a younger age group, and those with other medical conditions that are listed here, and those exposed to high-risk adults. For example, homeless individuals, those who are HIV positive, those who may go visit family who are incarcerated, and the like. And in an individual with no risk factors, an induration has to be at least 15 millimeters in order to be considered positive. Very importantly, prior BCG vaccination does not alter interpretation of the events, of the results. So if you're dealing with an individual who has been adopted and has had a previous BCG vaccination, interpret the skin test results exactly the same way. Now, what about interferon gamma release assay? It's recommended for all indications in which the skin test would be used. And its advantage is that it's an in vitro test of cell-mediated immune response to TB-specific antigens. In other words, the antigens are absent in the BCG vaccine. And that's why this is such a good screen for individuals who've had a BCG vaccine. It's the preferred test in adolescents who have previously been vaccinated with BCG. And just in June or July, I think, of this year, the Academy made a new recommendation that states now that interferon gamma release assay is preferred down to 2 years of age. It used to be 5 and above. Now it has been changed to 2 and above. So on your boards, I think the answer is going to be 5 because that is so recent. But know if you're taking boards in a year or two that the correct answer is going to drop from 5 to 2. But certainly in the adolescent population, history of BCG, do not do skin testing and do an IGRA. And you'll probably be given both of those options and as answer options following the vignette. All right, so let's talk in more detail about eating disorders. You should know the DSM-5 criteria for anorexia nervosa. Those are listed here in regards to persistent restriction of energy intake, intense fear of gaining weight and becoming fat, and several disturbances, for example, in one's body weight and shape and how that is experienced, an undue influence of body shape and weight on self-evaluation. And in DSM-5, the criteria for amenorrhea has been eliminated. And that is in recognition of 2 things. One is that the menstrual periods in someone who is lower in weight are going to be notoriously irregular anyway, and the recognition that more and more males are being identified with anorexia nervosa. There are 2 types, restricting type and binge eating and purging type. The definitions are here for you. But do remember that a fair number or a fair percentage of individuals who struggle with anorexia do practice purging behavior. So you're going to have to read questions carefully to try to differentiate the individual with bulimia who is purging and the individual with anorexia who has the purging type. And we'll talk about how to differentiate those 2 individuals in a few minutes. The lifetime prevalence is continuing to increase. It is still far more common among women than men, but it is becoming more common in young boys, more so than in the male adolescent population. Very frequently, family history is often positive. And I've had a couple of patients myself who, during caring for an adolescent with an adolescent with an eating disorder, for the first time, that adolescent's mom shares with her daughter that she too struggled or struggles with an eating disorder. So family history is very often positive. Unlike bulimia, there's a bimodal peak. It typically peaks around 14 years of age, and then again at the time of college entry, around 18 years of age. And comorbidities are very, very common, especially anxiety and depression, but also OCD, especially centered around eating and exercise habits. Substance abuse is not nearly as high as it is with bulimia, and it is more likely to occur in those who purge. So, which one of the following findings might you most often identify in a patient with anorexia? Heat intolerance, hypertension, dry vaginal mucosa, male pattern baldness, and slipped capital epiphysis. Good. So what you're looking for is evidence of lack of estrogenation, and so a pink, dry vaginal mucosa due to lack of estrogen. Most individuals are intolerant of cold rather than heat, are hypo rather than hypertensive. Their disorder is not associated with androgen excess, which is what D is referring to. And then a slipped capital epiphysis would be much more common in an individual who was overweight rather than underweight. So the symptoms and the signs are here. So these are some of the buzzwords that you might read in a vignette that will help to clue you into the fact that the vignette is discussing the possibility of anorexia. And other physical findings per system include the following. Again, oftentimes due to a lack of estrogen, the vaginal mucosa is dry and pinkish in color rather than more red and moist. And all of this is the result of secondary amenorrhea. And secondary amenorrhea is due to a reduction in the secretion of gonadotropin-releasing hormone, which therefore prevents ovulation, which therefore leads to what in essence is a functional hypothalamic amenorrhea. How about cardiac findings? Mitral valve prolapse is a relatively common finding as weight decreases. So the buzzword might be a click not heard on previous exam. Extremity edema may be associated as well, and there may be signs of pericardial effusion. So if you read that the heart sounds sound distant, or there is a pericardial friction rub, that too would be a buzzword for cardiac complications of this particular disorder. And functionally, again, oftentimes bradycardia, hypotension, arrhythmias, especially due to diastolic ventricular dysfunction, and dyspnea due to weakness and wasting of respiratory muscles. The latter is incredibly concerning to the adolescent because exercise in so many of these individuals is so very important. And oftentimes it's the inability to exercise at all or inability to exercise to the extent that the adolescent once was able to do that brings that individual into the office. And that's another example of something that I mentioned earlier, the presenting complaint, I can't exercise as much as I used to. You know, one certainly doesn't think of anorexia first. You wonder about pulmonary issues or cardiac issues. That's why you have to read the question so carefully and look for some of these other potential buzzwords. Gastroparesis is very common. When an adolescent says, I'm trying to eat, but I just can't eat, they're being oftentimes very truthful to you, and they're not being deceptive, because gastric slowing of GI motility is very real. You can see here that there's a large stomach bubble, and then contents of an enlarged fluid-filled stomach are really causing displacement of the transverse colon inferiorly. So delayed emptying of the stomach, especially in the latter stages of the disease and in the initial stages of treatment, is very problematic. Constipation, pancreatitis, and superior mesenteric artery syndrome. Adolescent presents with bilious vomiting, and that adolescent is described as having a low BMI. That's probably going to be superior mesenteric artery syndrome. Remember that the duodenum sits between the aorta and the superior mesenteric artery. As fat becomes less and less prominent in that area, the duodenum is obstructed by the aorta on one side and the superior mesenteric artery on the other side, because there's no fat in between those two arteries and the duodenum itself. So an adolescent with GI obstruction and bilious vomiting with a low BMI probably has that disorder, and that it might be a vignette that you see. Skin findings are numerous and illustrated here. Here's an example of lanugo. Although hair loss is common in young women with anorexia, the presence of lanugo hair is very, very characteristic. Okay, keratonemia may also occur, the yellowish discoloration that we'll sometimes see in an 8-month-old who loves sweet potatoes and carrots, etc. This keratonemia in this particular age group is of much more concern. And they like keratonemia on the boards because they try to trip you up into investigating it, and the treatment for it in the 8-month-old is carry on, and there's no problem at all, and they'll say that the conjunctiva are non-icteric, even though the skin itself appears jaundiced. Very similar to someone with anorexia. In anorexic patients, next question, which of these lab findings are you most likely to find? A leukocytosis, elevated LH, hypokalemia, hypernatremia, or an elevated hemoglobin A1C? Great. Okay, so this gets to what happens in individuals who purge and what are the potential complications. So there's lots of complications, and labs may be presented to you, and here's some of the buzzwords for abnormal labs associated with any individual who is purging. Hypokalemia, because of loss of potassium at the renal level. You're losing HCl, you're losing hydrogen by vomiting. So hydrogen and potassium exchange at the renal level, so you get hypokalemia as the body tries to compensate for the metabolic alkalosis that occurs due to vomiting. Pancreatitis is associated with purging, elevating pancreatic enzymes. Hypochloremia, for the reasons we talked about, losing HCl. And hyponatremia. Oftentimes, an anorexic, especially prior to a physician's appointment, will water load in an attempt to increase their weight. And personally, I've had 2 patients over the years who presented with seizures due to hyponatremia, secondary to water loading during just prior to an office visit. So hypo rather than hypernatremia. Also, there may be evidence of a fatty liver, abnormal cholesterol metabolism, and again, elevated carotene like we talked about before. So here are some of the abnormal lab findings that should clue you into the possibility of anorexia. Most have leukopenia, not leukocytosis, and some, but this is only at the stage where they are quite ill, will have a decreased sedimentation rate. Renal, again, probably going to be normal, but there may be issues with concentrating the urine and a low creatinine because of very little muscle mass. Endocrine labs. Prolactin will be normal, but just remember most everything else is going to be decreased. LH, FSH, gonadotropin releasing hormone, again, hypothalamic amenorrhea. A functional hypothalamic amenorrhea, very consistent with anorexia. Also, a euthyroid sick pattern, and the findings on thyroid functions are listed for you here, but the key is that treatment with levothyroxine is not indicated. These individuals do not need treatment with Synthroid. They need treatment to gain weight, and then their thyroid functions will return to normal. So this might be a distractor for your boards. They're going to try to get you to treat this patient. Treatment is not indicated. All right, let's move on to bulimia. Here are the DSM-5 criteria for bulimia: recurrent episodes of binge eating, recurrent inappropriate compensatory behavior, usually purging to prevent weight gain, and this is not uncommon, at least once a week for at least three months in a row. Self-evaluation unduly influenced by body shape, and again, this disturbance, here's the difference, the purging does not occur during episodes of anorexia. So what can you do as you read a question to try to sort through these? We'll talk about that. Much more common than is anorexia, almost exclusively in young women, and unlike the bimodal peak for anorexia, much more common in late adolescence and young adulthood. And the onset is oftentimes associated with risk-taking behaviors. These individuals tend not to isolate themselves all the time, but only during periods of binging. Whereas individuals with anorexia tend to be much more likely to isolate themselves at all times. Individuals with bulimia, much more social, much more willing to take high risk or to accept high risk behaviors versus the anorexic individual who tends to isolate him or herself. Physical symptoms. Buzzwords to look for in the vignette include cardiac symptoms, dizziness, lightheadedness, and syncope, as well as palpitations, bloating, and spontaneous vomiting, and severe weakness, muscle cramping, and tingling of extremities, all potentially associated with hypocalcemia. These individuals are usually described on your vignette as well-groomed versus the individual with anorexia may be described as the classic wearing multiple layers of clothes. With individuals with bulimia, they will be described as having either a normal or slightly elevated BMI, obviously very different than the anorexia, and may have some generalized or localized edema, parotid swelling, bruising on the dorsum of the hands, lacerations caused by the upper teeth during episodes of self-induced vomiting, so-called Russell sign, as well as some soft palate and posterior pharynx petechiae caused again by self-induced vomiting, and significant gingivitis and dental enamel dysplasia. So here's an example of an individual undergoing dental care who recently had her upper teeth replaced. You can see the difference in the dental staining. Again, Russell sign will be described as superficial excoriations on the dorsum of the hand. And remember, if you're shown a picture of parotid, or what you think might be parotid enlargement, so you see a big mass somewhere in this vicinity, the way to differentiate, is this parotid enlargement or is this a high anterior cervical lymph node, is they'll show you a picture of the individual from the lateral position. And if the angle of the jaw is absent, there is no doubt that it is parotid enlargement. Whereas if the angle of the jaw is not obscured, then it's a high anterior cervical lymph node. And sometimes that's a little bit difficult to differentiate. You'll see it most likely in the individual where the scenario is saying, is this mumps or is this cervical lymphadenitis? But again, for other reasons, parotid enlargement is very common, not only in individuals with bulimia, but in individuals with anorexia who purge. Now, what are you going to see on your labs that are presented in your vignette? Bulimia alone, altered glucose metabolism. Bulimia with vomiting, again, as we've discussed, basically a hypokalemic, hypochloremic metabolic alkalosis, and it's exactly the same as pyloric stenosis. So if you see a pyloric stenosis-like basic metabolic panel in an adolescent, that adolescent is purging. If there's also laxative abuse, then the findings can be all over the map, just depending upon what laxative is being used. And so chloride can either be elevated or decreased, normal or elevated sodium. All right, so they might ask you this question. They'll show you, let's say they show you a picture of an individual with parotid enlargement. And they say, in this patient, they might show you a picture of, say, the hand, or the picture of soft palate petechiae. In this patient, which one of the following EKG findings are you most likely to find? Because remember, a lot of your board questions will be several steps. So recognize, number one, this must be an individual with purging. Number two, remember the electrolyte disturbances associated with purging, which include hypokalemia. Number three, remember the EKG finding of hypokalemia, which is a U wave, which is illustrated here. So as the potassium decreases, the T wave becomes smaller and smaller. So let's say this is a normal T wave. The T wave is decreasing, becomes more bifid, and that's the U wave. And you'll see this in anyone who is purging or has hypokalemia for any reason. And that's just another example of how many of your questions are multiple steps. And that's why, again, I would suggest you always read the question first and then go back to the vignette. Because if I'm reading that vignette, I'm thinking, well, this is bulimia, and the last thing I'm thinking about is the EKG finding. So reading the question and then going back to the vignette, I think will help you read the vignette in a more effective way. So there's also something called binge eating disorder that you should be familiar with. These are episodes of binge eating that are defined by the following. These episodes occur at least once a week for greater than 3 months. And you can see the criteria here, but the key difference is there's no regular use of inappropriate compensatory behaviors. So they're very similar to individuals with bulimia, with the exception that they do not practice the various compensatory behaviors that we talked about earlier. So no binge eating disorder, and that's the way to differentiate it. Now, how do you manage it? I imagine you'll get some questions on the management of eating disorders. Obviously, stabilize the individual acutely and then work to reverse the various medical complications. The initial evaluation, appropriate screening tests are important. And so why would you get pancreatic enzymes in an anorexic? That's because she may be purging. Why would you get liver functions? That's because a fatty liver can develop. So think through the various labs that I showed you earlier, and that will help you to determine the best answer in regards to the various options that you are given. That's what I mean by a targeted laboratory evaluation. So, which one of the following findings is an indication for hospitalization in an adolescent with an eating disorder? So is it based on weight, A, based on heart rate, B, based on a systolic pressure of less than 90, orthostatic changes, or new onset of mitral valve prolapse? None of these are good, but which one should quickly put this individual in the hospital? All right, kind of all over the map. So C is the correct answer. So let's look at each one of these and what the criteria are. So here are the criteria. Systolic blood pressure of less than 90. The weight criteria is less than 75%, not less than 80%. The average heart rate is under 50, not under 55. And the orthostatic change is greater than 20, not greater than 10. And so these are very common questions. When should you hospitalize the adolescent with an eating disorder? When should you hospitalize an adolescent with PID? And so there are specific criteria that you should be familiar with, and they're listed for you here. Also, hospitalize if there's evidence of heart failure, recurrent syncope, esophageal tears, Mallory-Wise tears. Certainly, I think an adolescent who presents with hemoptysis is probably going to be a Mallory-Wise tear. And so keep that in mind as you're reading the vignette. Acute pancreatitis, uncontrolled seizures, probably due to an electrolyte abnormality, is something too that should prompt hospitalization. Now, what should the weekly weight gain goals be for the individual that you hospitalize? That depends on where they're being treated, be it outpatient, a partial hospitalization, or an inpatient hospitalization. The weight gain goals differ depending upon the location. So in the vignette, you're going to have to pay careful attention to where the treatment is taking place. Also, know this: begin treatment with a caloric daily intake of somewhere in the neighborhood of 1,000 to 1,400 kilocalories per day, which is extraordinarily low. But that's an important piece of information to know for your boards, because intuitively it may not make sense to start so low, but there are reasons to start low and then build up that we'll talk about. And once they are stable, the increase, again, should be relatively low and consistent. Increase by about 200 to 400 kilocalories every 2 to 4 days, knowing that you may need to get up to almost 4,000 kilocalories to gain appropriate weight. But very importantly, know where to start and know to go slow. Sort of like when you're transfusing someone with a hemoglobin of 5, you don't do it quickly because you're going to put them into congestive heart failure. Start slow and work up slowly with caloric intake. And expect normal menses and the return of ovulation somewhere around 85 to 90% of ideal body weight, because that's going to be a question that obviously patients may ask you, and I can see that being a board question. At what weight would you expect this young woman's menses to return? So during the initial stages of increased caloric intake in a hospitalized anorexic patient, which one of the following complications is most likely to occur? So hospitalized, refeeding has started. Is it hypophosphatemia, direct hyperbilirubinemia, hypercalcemia, hyperchloremia, or decreased TSH? All right, let's stop now. Good for you. So, refeeding syndrome, we don't need to talk about it. That's great. So, refeeding syndrome occurs within the first week or two of nutritional rehabilitation and marked by hypophosphatemia and volume overload. Remember that refeeding drives phosphorus intracellularly, and the scenario will be an individual, maybe in the ICU, who suddenly develops an arrhythmia, suddenly develops a change in mental status. Those are the buzzwords for refeeding syndrome due to hypophosphatemia, because hypophosphatemia has negative consequences in regards to cardiac function and sometimes in regards to mental status. All right, so how do you avoid refeeding syndrome? Again, this relates back to why you start slow and work up. So by slowly increasing the amount of daily calories and closely monitoring the patient, you can typically either avoid or quickly reverse the consequences of hypophosphatemia. So standard treatment for any patient will include nutritional rehabilitation, psychotherapy, individual therapy, cognitive behavioral therapy, which is much superior for bulimia than it is for anorexia. In general, treatment is more successful in bulimia than it is in anorexia, and certainly including the family if at all possible. Occupational therapy may be necessary, especially if the individual has certain aversions to the texture of foods, or if there are swallowing phobias associated with fear of gaining weight, or swallowing phobias associated with fear of induction of vomiting. And unfortunately, pharmacotherapy is not all that effective, and it's really not thought to be an initial or even a primary treatment for anorexia. Again, it is more effective in bulimia. Some individuals respond to the atypical antipsychotics, especially in patients not gaining weight. And some individuals, again, especially those who have anorexia, and especially those with various comorbidities of anxiety and or depression, will respond to SSRIs. But again, pharmacotherapy is not the initial or the primary treatment for this. So if you get asked a question, which one of the following is considered to be most effective in the treatment of an individual with an eating disorder, it's going to be, for example, cognitive behavioral therapy or family therapy, not pharmacotherapy. All right, so let's move on to various medical issues in young women. Then we'll move on to medical issues in young men and take a break. Or maybe we'll finish here. We'll just to see what time. All right, so keep in mind that breast self-exam is not recommended in adolescents for all these reasons. So the answer is not routinely recommended, and then they always hedge. And they say, but it may be valuable. So because it promotes self-awareness, it will certainly have value in later life. So the answer for the boards, not recommended, but in the real world, many young women are taught self-breast exams and continue with those self-breast exams as they grow older. But again, difference between real world and board exam. The most common breast mass is probably going to be multiple fibrocystic changes. This will be described as bilateral fullness in both breasts, oftentimes associated with pain and with tenderness, typically in the upper outer quadrants, and a direct association of an increase in pain with or just prior to menses, which typically then resolves following the onset of menses. Physical exam will be described as a nodular or a nodularity in the upper quadrants of typically both breasts. These are not particularly mobile or distinct from breast tissue. And that's a buzzword versus a fibroadenoma or a solitary cyst, both of which are distinct. The other buzzword for fibrocystic changes is bilateral versus unilateral for fibroadenoma or a solitary cyst. Treatment is symptomatic. Some improve by eliminating caffeine, and in some individuals who are especially symptomatic and do not respond to NSAIDs, oral contraceptives can be helpful. A breast cyst will be described as both fluctuant, smooth, and mobile, and its size may fluctuate with the menses, but again, this typically is not painful. It is typically unilateral and solitary versus bilateral for the fibrocystic nodular changes. Evaluation, the next best step is reassurance and observation. Mammography in adolescents is never indicated. If there is an option where it is necessary to further investigate the breast mass, it's always going to be ultrasound, never mammography, because it is less reliable due to the lack of fatty tissue. Aspiration is indicated only if the mass persists for at least 3 months, and the next best step is needle aspiration via ultrasound guidance, and the presence of non-bloody fluid proves it's benign, and that's it. So if the next best step question revolves around the fact that the aspiration is clear, the next best step is reassurance. Okay, there'll be a lot of next best step questions, and those are oftentimes difficult because a lot of the steps make sense. You just have to know the order with which those steps are recommended to be taken. So that's a breast cyst versus a fibroadenoma. These do not regress, nor do they change with menses. Again, a big difference between a cyst and a big difference between fibrocystic changes. They'll be described as more rubbery and firm, but mobile, distinct from the rest of the breast, typically no more than 3 centimeters in size, and again, usually in the upper outer quadrant. And thankfully, malignancy is almost never associated with a pre-existing fibroadenoma. Again, treatment is careful follow-up and reassurance. Most will decrease in size. The next bullet is 5 centimeters. If they're less than that size, you can safely observe every couple of months, and again, most will spontaneously resolve. If it does persist, then again, ultrasound, not mammography, and a ultrasound that is consistent with a fibroadenoma is the end of intervention. So if you document a fibroadenoma and you're given the option to excise or biopsy, the answer is no. On ultrasound, it will appear as a well-circumscribed, solid, and avascular mass. All right, let's talk some about amenorrhea, secondary and primary amenorrhea, and how you go through the differential diagnosis of both. So remember the players, and just a quick review. Remember that gonadotropin-releasing hormone is delivered to the pituitary gland with a resultant release of FSH and LH. The pituitary, after it releases FSH and LH, both of those stimulate the preantral follicles. A disruption in any of this pattern will obviously potentially lead to complications with menses. So you have to keep this in mind because you're going to have to identify where in this axis the problem might be. Next few slides just review the menstrual cycle again for you. I'm not going to go through it, but I put it in there for your reference, just to remember what FSH does and what LH does. Remember the importance of the fact that without an LH surge, ovulation does not occur. And that is extraordinarily common in young women, especially during the first year or two of their menstrual cycle. And we'll talk more about why that is in a second. So FSH and LH both have very distinct results on the ovaries as listed here. The follicular phase begins with involution of the corpus luteum, which, because there's decreasing levels of estrogen and progesterone, stimulate gonadotropin releasing hormone to release from the pituitary FSH and LH, which recruits ovarian follicles and begins to stimulate endometrial proliferation, which should, but certainly not always in young adolescents, triggers the mid-cycle LH surge, which is then associated with ovulation soon after the LH surge and a copious clear vaginal and cervical discharge, which you can see on the slide as ferning. That's followed by the luteal phase, where estrogen and progesterone production by the corpus luteum through negative feedback decrease production of FSH and LH. Importantly, endometrial growth ends and differentiates into a secretory phase. Why is that important? It's important because if you don't have the LH surge, endometrial growth will not end. And the risk is that endometrial growth, because of unopposed estrogen stimulation, will continue to grow and grow and grow, and then it outgrows its blood supply, and the individual adolescent has some bleeding. But that bleeding is irregular, that bleeding is incomplete, and that bleeding is painless. Remember, if you have a vignette that describes painless vaginal bleeding, it is due to anovulatory bleeding, which is due to unopposed estrogen stimulation causing unopposed endometrial growth. That's why this statement is so important, because that explains why young adolescents oftentimes have irregular menses and anovulatory cycles as they begin their menstrual periods. All right, so what are the definitions? They've changed a little bit. Used to be by 16, now that's dropped to by 15 with normal growth and secondary sexual characteristics, or individuals who at 13 years of age have a complete absence of secondary sexual characteristics. And you need to know these particular ages because it makes the difference between your answer being observe or intervene. Now, also at any age with secondary sexual characteristics, amenorrhea, and cyclic pelvic or abdominal pain. That definition and that description likely describes a young woman who has an outflow tract obstruction, and she should be evaluated right away. So those are your definitions of primary amenorrhea, which will tell you when to begin treatment or when to begin intervention and investigation and when not. So next question, excluding pregnancy, which one of the following is the most common cause of primary amenorrhea? Most common cause. All of these obviously can cause primary amenorrhea, but which of these is the most common cause? Okay, so the majority have got this correct. So let's go through these, because again, all of these are common causes, and let's talk about them in more detail. Keep in mind that all causes of secondary amenorrhea can also present as primary amenorrhea. And in both cases, the first thing to do is to check a HCG to rule out pregnancy. Now, the most common cause of primary amenorrhea, again, is chromosomal abnormalities associated with gonadal dysgenesis, Outflow tract disorders are next. A physiologic delay of puberty is next, then followed by PCOS, eating disorders, and on the rare occasion, hypothalamic or pituitary disease. And we'll talk about all of these in more detail. So again, chromosomal abnormalities. Most common, Turner syndrome. Now, menses may occur, especially if the individual is mosaic, but the amenorrhea is due to premature depletion of ovarian oocytes and ovarian follicles. And as was mentioned in the endocrine lecture yesterday, you're going to see Turner syndrome on your exam either at birth with lymphedema, low hairline, and a history perhaps of a maternal ultrasound that showed thickening of the nuchal area of the neck. Or you're going to see Turner present with a cardiac problem, either coarctation of the aorta or a bicuspid aortic valve. Or you're going to see Turner syndrome present with amenorrhea. Those are the three presenting signs that you'll probably be tested about on your boards. Now, individuals with gonadal dysgenesis will have elevated levels of FSH due to the absence of ovarian oocytes and follicles, and therefore there's a reduced negative feedback on FSH from a lack of estrogen. So, primary amenorrhea, anatomical causes. We just looked at Turner's, for example, as a genetic cause. Anatomical causes oftentimes present, the buzzword is, I think I'm going to have my period, and it never comes. For the last 2 months, I've had lower abdominal pain, but no bleeding. That is a scenario describing hematocolpus, which may be visible on examination of the genitalia, or may actually sometimes present as a perirectal mass on bimanual exam. So you're going to need to examine for anatomic abnormalities. The rarer anatomic abnormalities include Müllerian agenesis or vaginal agenesis. And we'll talk about the difference between vaginal agenesis and androgen insensitivity in a couple of minutes. But the main difference is what the value of the testosterone level is. Is it male or is it female? But we'll talk about that in greater detail. So those are the anatomic abnormalities that you need to consider in individuals with primary amenorrhea. Others will have primary amenorrhea due to a delay of puberty, but this is relatively unusual in young women. Constitutional growth delay, far more common in boys than it is in girls. That was discussed yesterday in the endocrine section, and it's really a diagnosis of exclusion. Patient with any chronic systemic disease or acute illness may very likely have primary amenorrhea. What about polycystic ovary syndrome? It may present with primary amenorrhea, and that's because of the high androgen levels, and especially if the individual is oftentimes overweight, or it may present with irregular cycles that then go on to lead to secondary amenorrhea. Polycystic ovary syndrome is diagnosed by two findings. One, evidence of hyperandrogenism. It's probably better to confirm this, but you can make the diagnosis if there's evidence of androgen excess on your exam. Male pattern baldness, extra hair, acanthosis, abdominal obesity, for example, and an abnormal menstrual pattern for gynecologic age for at least a year. So it really can be a clinical diagnosis supported by an abnormal testosterone level. But the diagnosis for PCOS in the adolescent population differs in this regard. So these are the two things that you need. Some of the physical findings: acanthosis nigricans, which I think you're all familiar with. Again, abnormal or prolonged menstrual irregularity may precede. So again, this can present as either primary or secondary amenorrhea. Lab findings, again, total and free testosterone will be elevated, but not absolutely necessary for the diagnosis. And as was mentioned yesterday, there is an abnormal LH-FSH ratio, typically more than 2.5 to 3 to 1, whereas normal is probably around 2 to 1. But these laboratory findings will support your diagnosis, but for your boards are not necessary to confirm your diagnosis. Ultrasound is definitely not indicated to confirm your diagnosis, and it's only used to exclude the rare adrenal or ovarian tumor, because you may very well see polycystic appearing ovaries in adolescents, because that's very common. Other causes, functional hypothalamic amenorrhea. We mentioned this before because this is the type of amenorrhea associated with eating disorders. So that's why it's going to be so important for you to read your vignette, because they're going to be giving you the clues. Is it PCOS? Is it a low BMI, making you think of an eating disorder? Is it someone with short stature, making you think of someone with Turner syndrome? And functional hypothalamic amenorrhea is basically a diagnosis of exclusion, and oftentimes associated with eating disorders, stress, and excessive exercise. And we've gone through the reasons why there is anovulation previously. This particular type of amenorrhea, as we've talked about before, is associated with low levels of estrogen, also low levels of leptin, which is a protein derived from adipose tissue. And FSH levels typically tend to be low normal. And in this case, there's a higher FSH to LH ratio, whereas it's flipped with PCOS. It's a higher LH to FSH ratio. Rarely, these are the rare causes, congenital gonadotropin-releasing hormone deficiency or hyperprolactinemia. And clearly the buzzword for hyperprolactinemia is the presence of galactorrhea. And almost all the time, issues of hyperprolactinemia are associated with secondary rather than primary amenorrhea. All right, what's the definition of secondary amenorrhea? You can see it here: absence of menses for at least 3 cycles with a history of previously regular cycles, or an absence of menses for 6 months in adolescence with a history of irregular menses. Again, always rule out pregnancy. And the disorders that cause secondary amenorrhea, we've talked about them already in terms of primary amenorrhea. They're listed here. Don't forget about thyroid disease. Typically, this is much more commonly associated with secondary rather than primary, and it can be associated with either hypo or hyperthyroidism. And again, PCOS and ovarian insufficiency. So a very similar list when you look at the causes of primary and secondary. Rarer, but more commonly associated with secondary than primary, are the tumors. So a craniopharyngioma, infiltrative disease, both of these affecting the hypothalamus. And in this case, the buzzword for the rare causes are going to be neurologic symptoms. Headache, personality changes, papilledema. Something is going to be different in your vignette that will clue you in to a central nervous system disorder, because again, these are indeed so rare. Pituitary disease, again, central nervous system, you're going to have those neurologic symptoms. There may be visual symptoms as well as the headache. And again, you're going to have galactorrhea. So the buzzwords are neurologic symptoms and galactorrhea if you're thinking about a central nervous system issue when you're reading your vignette. All right, so that's sort of the various list of differential diagnoses as you're presented with someone with amenorrhea. And it's a long list. So how can you, when you're reading your vignette, begin to sort through which one of the various causes is occurring. So read the vignette carefully and look for clues described on the physical exam. What are those clues? First, height and weight. Short stature, Turner syndrome. Extremes in weight may also delay menarche. Again, the anorexic, for example. The chronically ill individual who lost significant weight due to, for example, chemotherapy. Other clues on physical exam. Look carefully for information about the genitalia. Do they describe any abnormal, visible anatomic defect? Is the vagina patent? Is there an imperforate hymen? Is there evidence of vaginal agenesis or a transverse vaginal septum that you might be able to pick up on by manual exam, or they might describe by ultrasound? Because again, this is going to obviously indicate that the reason for the amenorrhea is associated with an anatomical defect or a rare disorder. Ask yourself this as you read the vignette: is there evidence of estrogen production? Because remember that thelarchy provides evidence of endogenous estrogen production. So if there is breast development described, likely there's evidence in that case of the presence of estrogen. And if you get a description of the vaginal area, again, how is it described? Moist, pink, and rugated indicates the presence of estrogen, whereas when we talked about the adolescent with anorexia, with the low estrogen levels, we talked about how the genital exam might differ. Now, as you're reading the vignette, most of the individuals with amenorrhea are going to be described as having normal breast development, but not all, but most will. So all of these disorders, if they are associated with amenorrhea, the individual in the vignette will be described as having normal breast development. And you can see that it's, the list is long and it continues here. But we've been through the majority of these, but it is important because there's going to be some disorders that are not associated with normal breast development that will be keys as you read through the vignette. There are also a couple of other buzzwords that you need to keep in mind. One is a history of an incomplete miscarriage or complications associated with an elective abortion that led to dilation and curettage. Amenorrhea that follows that procedure may be due to adhesions, and that is called Asherman syndrome. Another buzzword is excessive bleeding after delivery, which is then followed by amenorrhea. That is known as Sheehan syndrome, and it is due to a damage to the pituitary secondary to the excessive bleeding. So 2 more buzzwords to keep in mind. Now, you're reading the vignette, and now you learn that there's sparse or absent pubic hair in the vignette. Think of 2 things, and we'll talk about these in more detail: androgen insensitivity syndrome or Swyer syndrome. Keep those in mind, and we'll come back to them. So, you're reading the vignette: height and weight, history of chronic illness, genital exam for anatomic abnormalities or presence or absence of estrogen effect. Is there not breast development? Is there or is there not pubic hair development? All of those will help you hone in on the correct answer. So, thinking that through and beginning to get into the disorders that are not associated with normal breast development, answer this question: which one of these is associated with an elevated level of FSH? Constitutional growth delay, prolactinoma, Turner, Kallman syndrome, or treatment with certain antipsychotic medications? Great. Turner syndrome. Okay. So constitutional growth delay would be low or normal. Prolactinoma would be normal. Kallman is associated with absence of smell. That's an unusual cause of hypothalamic disease, and antipsychotic medications associated with galactorrhea. All right, so we've talked about normal breast development. Now, if breast development is absent or delayed, or if pubic hair is sparse or absent, again, you're reading your vignette carefully, or if the vagina and uterus are absent, what do you do? These are the labs that you consider: FSH, prolactin, testosterone, karyotype, pelvic ultrasound, or neuroimaging. All right, let's look at those more carefully. So now we've moved on to breast development, either absent or it's delayed, and pubic hair is normal. Now remember that patients will have varying degrees of breast development depending upon where in the pubertal process gonads fail. So some individuals with Turner syndrome will have no breast development, others will have some breast development, especially if they're mosaic, but it's not normal. What do you do when you read a vignette like that? If the FSH is high, then you know you're dealing with hypergonadotropic hypogonadism. And you therefore need to check a karyotype because you are likely to discover Turner syndrome, either mosaic or not, or you are going to develop a young woman with a normal, you're going to identify a normal karyotype in a young woman who has amenorrhea due to, for example, an autoimmune disease which has caused early ovarian destruction. But by far, the karyotype and the FSH, if the FSH is high, you're going to see an individual with Turner syndrome. Now, breast development is absent or delayed. Again, same scenario, normal pubic hair, same scenario, but now the FSH is low rather than high. You have hypogonadotropic hypogonadism. What's going on here? That's when you check an MRI or a prolactin, the next best step. So rather than checking a karyotype like you did when the FSH was high, you're doing some neuroimaging in this case to look for associated issues. This may be associated with constitutional growth delay, but again, that's uncommon. And your more uncommon but worrisome findings, like a prolactinoma or Kallman syndrome, which again is isolated hypogonadotropic hypogonadism with absence of smell. So, to summarize, if FSH is elevated, it indicates ovarian failure. If FSH is normal, it indicates an intact axis, and therefore you do a pelvic ultrasound because you probably have an anatomic abnormality. If FSH is low, your next best step is a brain MRI and prolactin. So that's how you can sort through, because every option they give you in terms of lab workup is going to make sense, but you work through it by paying attention to the information that you've been given on the vignette. So Turner syndrome, you've seen pictures of this. Remember another thing that boards love, lookalikes. The lookalike for Turner syndrome is Noonan syndrome, and the difference is Noonan has right-sided cardiac lesions, pulmonary stenosis, for example. Turner has left-sided cardiac lesions, bicuspid aortic valve, or coarctation, because the phenotype can look very similar between the two. All right, and very rare, if you're presented with someone who is hypertensive and has an elevated FSH, then that's going to be 17-alpha hydroxylase deficiency, which is a very unusual cause of congenital adrenal hyperplasia. But keep that in mind in case you're presented with someone who's hypertensive. Now, I mentioned earlier, what do you do if the vignette tells you about scant or absent pubic hair? Then you check testosterone and a karyotype. Not FSH and a karyotype, but testosterone and a karyotype. This will either be due to androgen insensitivity or to Swyer syndrome. And what's the difference? The difference is testosterone. Male testosterone levels and androgen insensitivity, very low testosterone levels in Swire. What's the difference? The androgen receptors are insensitive to testosterone stimulation and androgen insensitivity. And you can see the differences between these two in terms of gonads, in terms of breast development, and in terms of what structures are present or what structures are absent. This is an example like I talked about when you're doing studying. This is one of those examples where a side-by-side comparison in a brief flashcard can help you sort through. All right, what if your prolactin is elevated? This indicates a destruction of the pituitary stalk, either by trauma or by tumor. There are other causes like medications or thyroid disease. But again, the buzzword for prolactin is going to be galactorrhea. So dysmenorrhea, obviously very common among young women. Remember that anovulatory cycles are associated with painless bleeding. Ovulatory cycles are associated oftentimes with painful bleeding. And ovulatory cycles are related, when the individual begins her first ovulatory cycle is dependent in some degree on when menarche started, and that's listed there for you. And the pain is due to prostaglandins that are released from the secretory endometrium. And remember, the endometrium changes following the LH surge from a proliferative, then it stabilizes and becomes secretory. All right, what are other causes to keep in mind? Infections, endometritis, we mentioned Asherman syndrome before. That's, again, the one associated with previous surgical intervention following a incomplete miscarriage, for example, and any anatomic abnormalities. And there are non-gynecologic causes to keep in mind, especially if the vignette describes someone with, for example, Crohn's or ulcerative colitis. Endometriosis is another possible cause, relatively unusual in adolescents, but it can occur. The buzzword for that is lack of response to the treatment that one would expect would essentially resolve dysmenorrhea, which is going to be either with oral contraceptives or with NSAIDs. The other buzzword may be pain with defecation due to ectopic endometrial tissue. So relatively unusual, but you may see those buzzwords on your exam. How do you evaluate dysmenorrhea? It really depends upon the scenario. For example, if you're concerned about an STI, then obviously there's going to be a much more definitive and broad workup than if not. Again, NSAIDs and oral contraceptives will improve the vast majority of young women who complain of dysmenorrhea. Anovulatory uterine bleeding is the new term. It's replaced dysfunctional uterine bleeding. The definitions for anovulatory uterine bleeding are outlined there for you. And typically, this is due to an immature hypothalamic pituitary ovarian axis for all the reasons that we have discussed earlier. Again, during anovulatory cycles, like we've talked about, the lack of estrogen suppression on FSH leads to continued estrogen production. Continued estrogen production leads to continued buildup of the endometrium. There's no LH surge, therefore no progesterone produced, and the endometrial is therefore not stabilized. And that's what causes the anovulatory bleeding, because of the unopposed estrogen stimulation, like we've discussed earlier. So we've talked about all that. All right, other causes that may cause abnormal uterine bleeding. Don't forget about von Willebrand's disease. This is very common on your boards, and it's an individual who, upon the time of her first menses, or perhaps just her second and third menses with a previous history of very heavy menses, may indicate an underlying clotting disorder that has not previously been identified. The buzzword for that will be in the vignette. It will include this statement: no previous surgical procedures. Because the previous surgical procedure in someone with von Willebrand, say a tonsillectomy, will bring it to clinical attention. Other causes we reviewed in terms of thyroid disease and PCOS and excessive exercise. And keep in mind also that you may be dealing with an individual who is pregnant and perhaps losing her pregnancy, has an STI or other infection. All right, how do you treat it? It just depends upon the degree of anemia. It may just be reassurance and iron supplementation. With lower hemoglobins, there are recommendations also to include the use of oral contraceptives. The dosages are listed there for you. And if the hemoglobin is even lower, or if the individual is hemodynamically unstable, then obviously the treatment needs to be more aggressive, oftentimes with inpatient treatment, and at times blood transfusion. So in an individual on your vignette that is described as having abnormal uterine bleeding, and they're asking you about treatment, it depends upon the level of hemoglobin, whether it's just reassurance and iron and an outpatient oral contraceptive, or reassurance, iron, and inpatient and more aggressive treatment, all depending upon the vital signs that you're given and the hemoglobin that you are given. All right, real quick on contraception, just a couple of things to mention. Obviously, always recommend condoms to reduce the risk of STIs. Know this, that the first-line contraceptive of choice for adolescents by the Academy are long-acting reversible contraceptives, either a progestin implant, an intrauterine device, or depomedroxyprogesterone acetate. Know also that with the latter option, there is a black box warning that there is concern about the possibility of an increased risk of osteoporosis later in life. So keep that in mind. But the choice of the treatment, the contraceptive of choice, long-acting reversible contraceptives. While on progesterone injections, be sure that the patient is taking both calcium and vitamin D. Oral contraceptives have multiple actions, and oral contraceptives have multiple non-contraceptive benefits that you might be given the option to use. So for example, in eating disorders, in excessive exercise, in the female athletic triad. And it also reduces a number of risks, not only for infection and cancers, but in terms of discomfort associated with menses. So the option to use oral contraceptives as treatment for an individual who is not sexually active are still going to be relatively likely to occur on your boards. So because of that, you need to be familiar with these non-contraceptive benefits, but also you need to be familiar with the contraindications. And the main one to know is a history of migraine with aura. So someone who has significant androgen excess, someone who has significant abnormal uterine bleeding, and you're given the option to use an oral contraceptive, in your vignette, you're going to want to examine for possible contraindications to that oral contraceptives. And the most common is a history of migraine with aura. There are others, but most of them, if you look through this, are pretty unusual. Do note the recommendations for not using oral contraceptives if you are dealing with an adolescent who wishes to breastfeed or has recently delivered. And also, the other one you may be asked about is lupus. So remember that lupus is a contraindication. So migraine, lupus, probably a history of a previous clot, but most of these pretty unusual. So which one of the following is known to decrease the efficacy of oral contraceptives? Great. Okay, so rifampin, definitely the one. So the scenario will likely be prophylaxis, for example, for meningococcal disease, for a close contact, or close contact with someone with invasive H. flu disease. So know that there are certain anticonvulsants that do not reduce OCP efficiency. So I give you this list because if you are presented with an individual with seizures who desires oral contraceptives and does not have any other contraindications, there are only certain few anticonvulsants that will not reduce OCP efficiency. So those that do alter OCP efficiency are listed, those that do not here in this last bullet. Know also that rifampin is really the only antibiotic known to decrease the effectiveness of OCP. There's been some anecdotal reports about Grecia-fulvin. Know also there are other drugs, some herbal components, some other drugs, some as simple as antacids, some as complicated as antiretrovirals. So I give you this information because if it's in the scenario, you're going to want to choose another option for contraceptive. All right, emergency contraceptive options are listed here. They're now available without prescription to young women who are at least 16, by prescription for those under 16. Importantly, no lab tests are required, and it is not considered a teratogenetic drug. However, the other option may indeed be problematic in that case, but it is thought to be more effective in an individual who is overweight. Most of the individuals choosing to take emergency contraception will do just fine here. Know also that if you treat someone for emergency contraceptive, that a routine follow-up visit is not recommended. Menstrual bleeding should be expected probably within a week or so, and a pregnancy test should be performed only if there's no bleeding after 3 weeks or persistent bleeding. Know also that the AAP considers this standard of care, and again, you can see the various recommendations that are listed here. Most individuals do have some side effects, and those are listed here. But AAP very much considers this standard of care, so you should know that for your boards. All right, let's move on to males. Gynecomastia, very common. Cause is a decreased ratio of androgen to estrogen, and they're tender, asymmetric, in some young men, emotionally traumatic, but most resolve after 3 years. Keep in mind that there are some rarer causes that might show up on your boards. Probably Klinefelter would be the most common, and testes that are small is probably going to be the key buzzword. What's small? Remember that prepubertal testicular size is less than 4 milliliters. So if they tell you, they're not going to say testicles are small. They're going to give you a size. And the key is less than 4 equals prepubertal. So someone with gynecomastia and small testicles based upon that size, that's the buzzword for Klinefelter syndrome. Other causes may be the rare tumors and drugs of abuse, especially antibiotic steroids and marijuana and certain medications. So for the most part, treatment of gynecomastia, benign, reassurance. Some exceptions that are listed here. Again, like breast self-exam, testicular self-exam, not recommended, and then they say it's a good idea. Same thing. So board question, not recommended. Real world, different story. Now, what if you're presented with someone who has acute scrotal swelling? You can see that some are painful, some are painless, and with the exception of hernias, which can be acute, chronic, painful, or painless, this is a good little chart to keep in mind when sorting through the differential if you get a question about scrotal swelling. Hydroceles, the buzzword is going to be soft, painless, asymptomatic mass anterior to the testes that typically transilluminates. That hydrocele may or may not change with Valsalva, but it's important to know the difference because communicating hydroceles, which do change with Valsalva, should be repaired, whereas non-communicating do not necessarily have to be repaired. So know that difference because that's going to make a difference in the answer to your question. Again, hydroceles, communicating should be repaired, and if they are symptomatic. Spermatoceles, the key buzzword, distinct from the testes, a small pea-sized mass that may transilluminate. So hydrocele transilluminates, spermatocele transilluminates, huge difference in the size. Spermatocele being pea-sized, hydrocele being described as significantly larger. Typically described, I was in the shower and I noticed this bump and I am afraid that I have cancer. No clinical consequence, and unless there's significant discomfort, which is rare, you don't need to do anything. Varicocele, again, as was mentioned yesterday, bag of worms is the buzzword for that. Benign, but not if they're on the right. Because if they're on the right, it could be associated with an intra-abdominal mass or with hepatosplenomegaly. So sort of the routine response to varicoceles or reassurance, but make sure they describe it on the left, because if it's on the right, you're going to need to work that patient up. And here's when to repair. Again, there may be some infertility because, as was mentioned yesterday, the environment is warmer because of the additional presence of blood. All right, a cremasteric reflex is typically absent in which one of the following disorders that are listed here? Absent cremasteric reflex. All right, good for you. So testicular torsion. So let's talk about torsion versus epididymitis. If it's painful, it could be torsion of the testes, the appendix testes, epididymitis, or orchitis, or an incarcerated hernia. With testicular torsion, the vignette will describe the sudden onset of acute pain, nausea and vomiting, lack of history of trauma, and lack of fever and urethral symptoms. Fever and urethral symptoms should lead you towards epididymitis and away from testicular torsion. On physical exam, it will be described as edematous, indurated, and erythematous, tender, swollen, important buzzword, slightly elevated, and more positioned horizontally rather than vertically. Buzzwords, high riding, abnormal position, that's torsion. The abnormal position is described here. Pain is not relieved by elevating testicle. That's called Pren's sign, P-R-E-H-N. That differentiates it from epididymitis because that pain is improved by raising the testicle. And the cremasteric reflex is typically absent in torsion of the testes, present in epididymitis. It's oftentimes a clinical diagnosis. Next best step in the evaluation should be a Doppler ultrasound. You can see that on this patient's left, there is no blood flow to the testicle when compared to the right. So this is the diagnostic test of choice in someone that you feel may have a testicular torsion. Remember, it's a surgical emergency. Certainly, this is one of the cases where observation is not the right answer. And the reason for that is the viability of the testicle rapidly decreases after a relatively short period of time. Now, torsion of the testes, the buzzword is a pea-sized mass, tender, that is superior or inferior to the pole. But if they're really nice to you, they'll describe a bluish discoloration of the scrotum, the so-called blue dot sign, which is due to the gangrenous or blackened appendix that's visible through the scrotal skin. Treatment for this is reassurance. Doppler is not necessary unless you cannot differentiate it from torsion. And if you do a Doppler, you're going to see flow that's either normal or increased, exactly the opposite that you would see with testicular torsion. So tender, pea-sized mass, anterior or inferior pole, blue dot sign, all buzzwords for this particular disorder. Epididymitis should be considered an STI in adolescents. The infectious agents are listed here, and they are those that you would expect in sexually active individuals. And in regards to history and physical exam, fever, urinary frequency and dysuria is present. Urethral discharge may be present, very different than torsion. And again, elevation of the testes alleviates the pain, unlike torsion, and the cremasteric reflex is present, unlike torsion. So, the position of the testicle is normal, unlike torsion. So read your vignette carefully and you can pretty well know the difference as to whether they're after epididymitis, whether they're after a testicular torsion or a torsion of the testicular appendix. And diagnosis is really a workup from an STI perspective and appropriate treatment. All right, orchitis, mumps, is really the one you need to keep in mind, although don't forget parvovirus. I've seen a question about a adolescent who was in the same home as his younger brother who had Fifth's disease. Then the adolescent developed testicular pain. What was the etiology? And they were obviously the key was the history of parvovirus in the household. Clinical manifestations are listed here, and basically treatment is symptomatic. So those are the painful testicular masses. Generally, neoplasms are painless. The vast majority are germ cell tumors, and this will be covered in much greater detail in the HEMONC lecture, so I'm not going to go through it any further, except to say that, again, it's typically painless unless there's associated hemorrhage or metastatic disease. All right, so let's run through sexually transmitted infections. We'll start with genital herpes simplex, an increasing proportion of cases now due to HSV-1. Still, the majority are due to HSV-2, but there have been more recent cases of HSV-1 causing genital herpes as well. Whenever you see the description, grouped tender vesicles, they're talking about HSV. No doubt that is an important word grouping to keep in mind. And then typically primary infection follows 12 to 14 days after exposure with systemic symptoms that can be pretty significant. Fever and headache, especially myalgias, can be quite significant with primary infection, dysuria, and associated lymphadenopathy with a definite positive response to the antiviral agents in regards to shortening the course of the disease. That's different in regards to recurrent infection, which may actually be relatively asymptomatic, and the antivirals don't have much of an impact at all, not only on the symptoms, even if there are some, but on the clinical course. Typically, patients will complain of a burning sensation. Sometimes that burning sensation can actually precede the appearance of the lesions. And whenever you hear the words burning or paresthesias when pain is described, think herpes, be it herpes zoster, when I don't want to put my t-shirt on because it hurts so bad. That can precede the dermatomal distribution of zoster. Dysuria and frequency can precede the appearance of lesions with genital herpes. Confirm it by PCR. That's most sensitive if you're given a variety of ways to confirm. PCR and culture are preferred for active genital lesions, whereas serologic testing is preferred to evaluate the potential for past disease without any current active disease. You see good examples here of the grouped tender vesicles that were described before. And one thing that clinically you should not use, but still sometimes shows up on the exam, is a zinc smear. You unroof the vessels and stain it and looking for these multinucleated giant cells, but this is both insensitive and nonspecific. You can have a zinc smear that's positive from varicella, for example, as well as herpes. But it still might appear on your exam, but it certainly is not the choice in regards to how best to diagnose herpes. That's going to be, again, PCR or culture. Treatment is outlined here for both primary disease as well as recurrent disease. Remember that in recurrent disease, if you're treating, it's best to start within 24 hours. And then for those with multiple episodes of recurrent disease, the suppressive doses of the antiviral agents are listed there for you. Okay, so which one of the following best describes the ulcer or ulcers that are typically associated with primary syphilis? So this kind of begins the discussion of how to go through differentiating the various genital ulcers. A, multiple grouped painful lesions. B, punched out painless lesions with sharp borders. C, painful deep-seated lesions with a grayish yellow exudate. D, large, extensive, painless lesions with red, friable granulation tissue, or a single painless, indurated nodular lesion. Okay, so we'll work through these. B is the correct answer, and we'll work through all of these descriptions. We've already described herpes as multiple grouped painful lesions, and so let's look specifically at the genital ulcers and the various ways to differentiate those. So starting with syphilis, syphilis is painless, and it may actually go unnoticed. And the ulcer is typically described as very clean and punched out with sharp, firm, raised, indurated borders. Inguinal lymphadenopathy can vary from mild to moderate, and it typically heals in 6 to 8 weeks, and as I said earlier, may go unnoticed by the individual. Now, secondary disease is associated with systemic symptoms, much more lymphadenopathy. Epitrochlear nodes in particular might be a key bit of information for your boards, and a polymorphic maculopapular, keyword here, copper reddish lesions. The only 3 skin rashes that I'm familiar with that you might read about copper reddish lesions are these: secondary syphilis, pityriasis rosea, or the amoxicillin rash that follows or is associated with EBV infection, like we looked at yesterday. The key difference between pityriasis and secondary syphilis is with secondary syphilis, you'll have lesions on the hands and the feet. And with pityriasis, you will not. And that particular disorder is typically from sort of the mid-neck down to the mid-buttocks in the so-called Christmas tree distribution. So if you have a pityriasis-like rash that includes the hands and the feet, and you're asked how best to confirm your diagnosis, the answer would be with an RPR in regards to lab evaluation. Secondary syphilis can also be associated with condylomata lata, illustrated here, and sometimes with hair loss, bony changes, especially periostitis, so the patient may complain of pain in regards to movement of a limb, and eye involvement. So much more serious, much more systemic, and again, this may be the way it presents because the lesion itself is painless and may go unnoticed in primary disease. Now, you should probably know the definitions of syphilis in regards to what it comprises early syphilis. Again, we've been through primary, we've been through secondary, excuse me, and then early latent disease, which is defined as disease within the first year of initial infection, but this is totally asymptomatic and therefore can only be demonstrated by serologic testing. So I'm quite sure that if you're going to be tested on syphilis, it will be primary or secondary disease, not early latent disease, and probably not tertiary syphilis because you're just not going to see this in the pediatric population. So if any of you, for example, are med peds, tertiary syphilis may indeed show up on your internal medicine boards, but this is not going to show up on your pediatric boards. And neurosyphilis, remember, can occur at any time during the course of infection. And the key, most common presentation that you're going to read about on your boards will be the sudden development of hearing loss, most often without, but sometimes with signs of neurosyphilis in regards to meningitis. So new onset hearing loss, that is a buzzword for the potential for early neurosyphilis. And again, late neurosyphilis, you're not going to have on your pediatric boards. Now, how do you evaluate? It's important to know the difference between the non-specific or non-treponemial tests, VDRL and RPR, and the specific treponemial tests that are listed here, the FTA and the TPPA assays. Now, why is this important? It's important for this reason. Remember that the non-treponemial tests correlate well with disease activity. So if you're asked this question, you treat someone with syphilis, maybe it's a newborn, maybe it's an adolescent, how do you document that treatment has been successful? And the answer is by obtaining a non-treponemial test, usually RPR, and looking for an appropriate fall in that titer. So has this newborn been treated appropriately? Confirmed by a dropping RPR. The reason for that is the treponemial tests themselves remain positive for life. So even after adequate treatment, they will still be present in regards to serologic testing. So for the initial diagnosis of someone with syphilis, the recommendations are as follows. Screen with an RPR. If that RPR is positive, confirm with a specific test. Then treat the individual and confirm that treatment is successful by demonstrating a fall in the RPR, remembering that the specific treponemial tests remain positive for life. So that's how to differentiate on a answer which particular test you obtain and at what time. Okay, how do you treat syphilis? Just remember penicillin. The dose varies a little bit, not in terms of the amount of penicillin, but rather in the terms of the number of required doses. So it's 1 dose for primary and secondary disease, 1 dose for latent disease, and 3 doses for late latent disease. But again, this particular one you're probably not going to see on your boards, so it's pretty straightforward. PenG, 2.4 million units, one time, followed by an RPR to be sure the treatment was successful. Penicillin is far preferred over the option of doxycycline simply because one can be sure that treatment has been completed. Okay, and neurosyphilis, the particulars of treatment are outlined there. Now let's move to chancroid. Certainly syphilis and chancroid are going to be the most likely to appear on your boards, but others that we'll be talking about in a second you should also be familiar with. The big difference is this is a painful rather than a painless lesion. More common among individuals who live in developing countries or urban commercial sex workers and their clientele. This is caused by Haemophilus ducreyi, and the thing to remember about chancroid is you can identify by unroofing a lesion the so-called school of fish, which are the gram-negative organisms that typically appear in chains, and that's where the term school of fish comes from. Also, these individuals typically develop very suppurative, painful, unilateral adenopathy, illustrated here, and they may actually become so fluctuant that they rupture. So painful, not painless. Treatment and is in a second, but let's again try to look at both the similarities and the differences, because I think these are the two that you're going to be most likely tested on. Both syphilis and chancroid begin as pustules at the site of inoculation that progress to ulcerated lesions. They're about the same size and typically appear on the genitals. However, there's important differences. One is the absence or presence of pain. Second, the description will vary. So one of the descriptions on the original AR question that we had was describing chancroid, because that's the one with the grayish yellow exudate versus non-exudative for syphilis. And then another is the difference between the borders. So this is worth memorizing because as you read the vignette, if you pay close attention to how the lesion is described, you can pretty well tell the difference between these two. Here's treatment for chancroid, and you can see that certainly these would be preferred because we know that treatment indeed took place because it can be observed. All right, you may be asked about some of the more rare genital STIs as well, so we should go through them. And granuloma inguinale is a painless ulcer, but here, this was another choice in the AR, is the description of the ulcerative lesion. Much more red and friable, so-called raised and rolled margins, which you can see illustrated here. Inguinal adenopathy is typically relatively uncommon, which is another key for granuloma inguinale, because the majority of other STIs associated with genital ulcers have much more significant lymphadenopathy. And then this is characterized by so-called Donovan bodies. So we talked about school of fish, and now Donovan bodies, which again, if you obtain a small biopsy, it's so-called crush biopsy, you can identify the Donovan bodies as intracytoplasmic inclusion bodies. So there's always going to be a couple of key words to look for to help you differentiate these. Granuloma inguinale treatment is outlined here for you. And oftentimes, if you simply can't remember the treatment, azithromycin is always going to be a good choice if you're just not sure. All right, another unusual one, but one that you may get tested on, is lymphogranuloma venereum, caused by chlamydia trachomatis specific serovars that are listed here. This is a painless lesion, herpetiform-like ulceration, and in its secondary stage, the buzzword for this is the groove sign, and that is a separation of the inguinal and femoral nodes by the inguinal ligament. So the ligament separates large nodes both above and below it, and that's where the term groove sign comes from. Again, much less common in the States, so if the vignette says recently back from a subtropical region, that could be a huge clue that you're dealing with lymphogranuloma venereum. Lymphogranuloma venereum, like we talked about yesterday, may also be associated secondary infection following receptive anal intercourse or sexual abuse. So this is the same slide I showed yesterday in adolescent medicine, but just as a reminder, LGV serovars can be causative agents for both proctitis as well as proctocolitis. And here are your options for treatment in regards to lymphogranuloma venereum. Okay, so let's summarize it. Here's high yield for genital ulcers: HSV, grouped vesicles, and shallow; chancroid, deep, ragged, yellowish; syphilis, single, soft, indurated, well circumscribed; LGV, single papule or shallow ulcer. That's the final option that was on AR, whatever the number was. And then granuloma inguinale. So this would be a good high-yield slide to commit to memory to help you sort through these. What about lymphadenopathy associated with the ulcer? It's very common, as I said earlier, with most. It can be tender with some, HSV, chancroid, and LGV. It could be more rubbery and non-tender, syphilis, and it might be more often described as matted and or suppurative with chancroid and LGV. And again, as I said earlier, less common with granuloma inguinale. And if there is a genital lesion and the description includes widespread lymphadenopathy, that's likely due to HIV and concomitant infection with HIV. All right, what's painful? HSV and chancroid. What's painless? Syphilis, LGV, and granuloma inguinale. Recurrent, HSV. And constitutional symptoms, these three. So those three last slides, I think, would be good to commit to memory and would help you with any question that involves a genital ulcer caused by any of these organisms. Okay, let's move on to chlamydia. Most common bacterial STI. The majority are asymptomatic, which again goes back to the recommendation that we went through yesterday to screen all sexually active adolescent women on an annual basis, and if a male is at high risk, to screen him as well. Infants are at risk. We talked about conjunctivitis yesterday. We talked about pneumonia yesterday. I think one thing I forgot to mention yesterday with pneumonia, the cough is also oftentimes described as staccato-like, whereas the cough with pertussis will be described as whooping, and then the cough with RSV always associated with profuse nasal discharge. So the 6 to 8 week old with a cough and pneumonia is going to have RSV, chlamydia, or pertussis, and the description of the cough and associated symptoms can help you sort through those. Okay, genital chlamydial infections, here are the causes. And what does it look like in males? Majority, again, are asymptomatic. If there are symptoms, typically the urethral discharge would be described as mucoid or watery, and it's oftentimes seen only with milking the urethra. And on gram stain, you'll see quite a few poly-PMNs per high-powered field, but there will not be organisms. Acute epididymitis may be associated with either asymptomatic urethritis, chronic prostatitis, again, proctitis, and reactive arthritis. Chlamydia, one of the many organisms associated with reactive arthritis. Remember, GU and GI organisms typically associated with reactive arthritis. Cervicitis will be how chlamydia typically presents in women. If there are symptoms, they'll be associated with UTI-like symptoms or abnormal bleeding, or perhaps a vaginal discharge, typically described as very mucopurulent, and importantly, intense cervical erythema, very common associated with chlamydia, and again, lots of polys on gram stain of the cervical discharge. Remember also, in a sexually active woman who presents with UTI-like symptoms and negative cultures on urine culture, that's very typical of chlamydia, the so-called dysuria, pyuria syndrome. So the scenario on the vignette will be, in spite of suspicion of a UTI, cultures have been persistently negative. Think chlamydia in that particular case. Also associated with PID and Fitzhugh-Curtis syndrome, both of which we'll talk about more in a second. So, diagnostic tests of choice are here. Again, I think in the real world, most everyone diagnoses both men and women with examination of the urine, but this is preferred information for your boards. Know also that the NAAT can be performed during a pelvic exam. Other screening options, again, first catch urine testing, self-collected vaginal swabs. Treatment, again, azithromycin, probably going to be your favorite choice for any STI. Doxycycline is almost always correct as well, but again, the disadvantage is it's not a one-time treatment. Treatment, if an individual is pregnant, should not include doxycycline, so your choices are either azithromycin or amoxicillin. But importantly, and this is an exception to what we were talking about yesterday, because cure rates are lower in women who are pregnant, be sure to perform a test of cure in about 3 weeks. Very different from what we were talking about yesterday when we talked about testing in 3 months following initial infection. So here's the exception to the recommendation that test of cure not be performed. Epididymitis, also, this is a little bit different. This is the one case where azithromycin is not the correct choice because it has not been studied, and so it's doxy and ceftriaxone rather than azithromycin and ceftriaxone for epididymitis. But that's an exception to the general rule that erythromycin can be used. And then if there's concern about enteric organisms, you'll want to add additional coverage for those organisms with any of these options. So dropping the doxycycline and using one of the floxins instead. And proctitis, we have reviewed before. And on to gonorrhea. Small, non-motile, gram-negative diplococci. Highest attack rates are in the adolescent population, and you can see that male to female and female to male transmission rates do differ a little bit, but obviously with multiple exposures, individuals are at greater risk of infection. Urethritis, again, will be described in essentially the same way as chlamydial urethritis. So in a vignette, there's really no way to tell the difference between a urethral discharge due to chlamydia and a urethral discharge due to gonorrhea. And local manifestations of gonorrhea in males can include all of the following. Some depend upon sexual practices, but you can see that local manifestations can occur in a variety of anatomical sites. In women, again, oftentimes asymptomatic, but if symptomatic, very similar to chlamydia in regards to bleeding, UTI-like symptoms, vaginal discharge, and cervical erythema, friability, and mucopurulent discharge on pelvic exam. So once again, difficult clinically to differentiate between gonorrhea and chlamydia. And here are the various local manifestations associated with genital infection in women. All right, the diagnosis can be made presumptively only in males with a gram stain. Here, the gram-negative intracellular diplococci. And again, nucleic acid amplification test is the preferred mechanism to make the diagnosis. How do you treat it? Dual therapy. This is important even if gonorrhea is positive and chlamydia is negative. Dual therapy is still recommended because of trends in antimicrobial resistance and also due to the lack of new antimicrobials. So dual therapy means ceftriaxone plus azithromycin. And that's, I would think, some particular question they try to trip you up on by telling you chlamydia is negative, but again, the right answer is to still include azithromycin. There are cephalosporin alternatives, but it's important to remember that if a scenario presents pharyngeal gonococcal infection, that those cephalosporin alternatives are thought to be less effective. All right, so which one of the following findings is most likely to be identified in a patient with monoarticular suppurative arthritis secondary to disseminated gonococcal infection? And so this question will help us sort through the two types of disseminated gonococcal infection. So which one of the following will be associated with monoarticular suppurative arthritis? Good. Okay, so let's sort through these. That's the correct. The majority of you got the correct question. So there are two types of disseminated gonococcal disease. One is the scenario that we just described, suppurative or purulent arthritis. And in an adolescent with monoarticular arthritis, consider disseminated GC until proven otherwise, especially for your boards. It's more common in women and more common among women who are asymptomatic, and oftentimes it occurs around the time of the last menses, because during menses it is easier for the gonococcal organisms to migrate into the fallopian tubes, and so that might be a hint on your vignette that soon after completing her menses. Purulent arthritis is typically large joints, one or more. There are no skin lesions, otherwise absent systemic symptoms. Blood cultures are typically negative. Synovial cultures may be positive in upwards of 50% of individuals. That's suppurative arthritis, one of two types of disseminated gonococcal disease. The second type is tenosynovitis dermatitis. This particular one does have systemic symptoms, and the arthralgias, rather than being in the large joints, are in the small joints and the tendons of the hands and the feet. So the vignette will say, I have trouble making a fist. It's painful when I walk. And purulent arthritis in this form of disseminated disease is absent. And the skin lesions look like this. And oftentimes you can identify gonococcal organisms within these skin lesions. They're quite painful, and they're not all that numerous in number. Blood cultures may be positive. Synovial cultures are always negative. So again, keyword, soon after menses, develops a painful joint. Soon after menses, complains of pain throughout fingers and toes. Those are the two types. It only occurs in about 3% or so of individuals who have GC. Again, much more common in women, but something that is likely to appear on your boards. The treatment for disseminated disease is outlined here. It's obviously much more robust than the treatment for isolated disease, as you can see here. Here's another example of the lesions associated with tenosynovitis dermatitis syndrome. Okay, bacterial vaginosis. Most common cause of vaginitis in adolescents, often asymptomatic, and vaginal pruritus is very common, and the pH is elevated. That's important. The normal vaginal pH is less than 4 typically, but what happens with bacterial vaginosis is the various organisms, anaerobes, Gardnerella, replace the normal lactobacilli, and replacement of normal lactobacilli by these organisms causes an increase in vaginal pH. The other key description that will help you identify bacterial vaginosis is a homogeneous grayish-white discharge that coats the vaginal walls. Oftentimes the cervix is not at all friable, not at all erythematous, and then if they show you a picture of clue cells, that certainly makes your or confirms your diagnosis. The organisms typically line the cells, almost look like you take a sharp pencil and make little lines all around the periphery of the cells. So the type of discharge, the elevated pH, the lack of inflammatory changes, all should help you identify BV. Sequelae are significant. It can be associated with preterm birth and other complications of delivery, as well as PID, and seems to be associated with acquisition of other STIs. Treatment is here. Another caveat about bacterial vaginosis, because it's associated with changes in the vaginal flora, partners are not treated. It's the only STI where partners are not treated. Otherwise, partners should always be treated. Trick, key, if they describe a punctate cervical hemorrhages, as you can see here. With trick, the vaginal pH is elevated as well. Typically presents more with UTI-like symptoms than does BV. And the trick in males is almost always asymptomatic. Again, keynote, buzzword, strawberry cervix, cervical hemorrhages. Sequelae, again, similar to bacterial vaginosis in terms of complications during pregnancy. Here are the flagellated, pear-shaped motile organisms that you might see on wet prep. Again, treat all sexual partners. Here is treatment options. All right, what about pelvic inflammatory disease? It's an ascending polymicrobial infection involving the uterus, fallopian tubes, and ovaries. So again, PID tends to occur soon after menses, with a variety of complications, infectious complications, that you can see listed there. Now, keep in mind that you may get a distractor on your boards with an ectropion. Here's an example of an ectropion. And this is due to an eversion of the endocervix, which exposes columnar epithelium. So the columnar epithelium appear more red. And they might try to confuse you and distract you to think that an ectropion actually represents an STI. But clearly, with an ectropion, you should see no discharge. And the redness associated with cervicitis tends to be a little bit more intense than does an ectropion, but this is a normal finding in young adolescents and actually explains why some adolescents are at risk of HPV infection, because the columnar cells are more easily infected than are the squamous epithelial. So don't be distracted by that difference. Don't forget Fitzhugh-Curtis syndrome. Sexually active woman presents with right upper quadrant pain. The distractor might be gallstones, but this right upper quadrant pain may or may not be associated with other symptoms of PID, but you will see mention of sexual activity. This is an inflammation of the liver capsule, and sometimes described as violin strings. And importantly, the LFTs are normal. And the reason that they're normal is this is an inflammation of the capsule, not an inflammation of the parenchyma of the liver. And so this is a scenario where the signs and symptoms might be not so prominent in regards to cervical motion tenderness, for example, but right upper quadrant pain on palpation and percussion of the liver should clue you into Fitzhugh-Curtis. Typically caused by chlamydia, can also be caused by gonorrhea. So how do you evaluate an individual for PID? Certainly always perform a pregnancy test, wet prep, NAATs for both chlamydia and gonorrhea, and likely more additional STI testing, and then looking for signs of infection with a CBC and acute phase reactants. If you're concerned, for example, if the young woman looks especially toxic, if there's the potential of a mass on pelvic or bimanual exam, then be sure to get an ultrasound, not only to rule out an abscess, but perhaps an associated ectopic pregnancy. The evaluation in regards to criteria, the criteria for PID are really very minimal, and that's purposeful because you don't want to miss PID and not treat it because the consequences are significant in terms of infertility. So here's the criteria: pelvic and lower abdominal pain with one or more of these three findings: uterine tenderness, adnexal tenderness, or cervical motion tenderness. So all you need, not all you need, but an abdominal pain and just one of these three, then the next best step in the treatment is to indeed treat, not further evaluate. Now, what would support it? Most of the young women are febrile, have a vaginal or mucopurulent discharge from the cervix. There is some signs of cervical friability, lots of white cells per high-powered field, elevated acute phase reactants, and obviously may have positive cultures. However, if the cervical discharge is not mucopurulent and there is an absence of white cells on high-powered field, the diagnosis of PID is unlikely. So keep in mind these, minimal criteria. Support your suspicion with additional evaluation, both on physical exam and by lab, but realize that if there are an absence of white cells on the cervical discharge, you probably are not dealing with PID. When should you hospitalize? Again, favorite question for your boards. In the next best step, they'll give you options to treat as an outpatient, options to treat as an inpatient. And so here are the criteria that are recommended. An older recommendation was to hospitalize all adolescents because of the concern about infertility. That's no longer recommended, but certainly if they've not responded to outpatient treatment or they appear particularly ill, perhaps have a surgical emergency, such as a tubo-ovarian abscess, and certainly all individuals who are found to be pregnant and have PID should be hospitalized. The various inpatient treatments, there's a variety of treatments. I think you're just going to have to commit these to memory if you're given treatment options. There's so-called Regimen A listed here, or Regimen B listed here, but you can transition to oral therapy to complete doxycycline, for example, after the individual is afebrile and feeling significantly better. So these are the specific recommendations for inpatient treatment, and here's the specific recommendations for outpatient treatment. So if you read your vignette and none of those criteria for hospitalization are described, then outpatient treatment would be the correct answer, and here is when to do so. If there's concern about anaerobic infection, be sure to add coverage for those. That will likely be a scenario that includes this statement: recent instrumentation, associated typically with a dilation and curettage for a incomplete miscarriage. And again, recommended with an increased risk: pelvic inflammatory abscess, proven infection with trich or BV, or again, gynecologic instrumentation within the last several weeks. HPV, we talked about yesterday in terms of the vaccine, and we'll look at it quickly again when we talk about immunizations in a couple of days. Again, inhalation transmission by infants through the infected canal. This is where respiratory papillomatosis should have been when I called your attention to that mistake in a previous slide. We talked yesterday about which particular serotypes cause which particular diseases. And these can be asymptomatic as well, or can be associated with local symptoms of itching, burning, pain, and tenderness. The location of the HPV lesions will in some way determine how they look. So they can be described as fleshy or gray, or flat and not visible to the eye. This is especially common for HPV lesions that line the vaginal walls or perhaps are on the cervix. So not all HPV lesions are the typical warty, elevated appearing lesions that you see here. And some can actually be described as spiking. There are lots of different treatments for them. The main take-home message: no treatment is superior to another, and very importantly, treatment does not eradicate the virus, nor does it modify the risk of subsequent development of cervical dysplasia and/or neoplasm. And you should switch to a different therapy in regards to HPV if you either don't get a response at all within 3 weeks or have a lack of complete clearance after 12 weeks. So the vignette would be someone previously treated, know better what to do, and when to switch treatment is outlined here for you. Biopsy is not routinely recommended unless the individual is immunocompromised. in regards to treatment. And there's lots of different treatment options that are all listed here for you in case they ask you about it. Some are patient applied, some are provider applied. Again, one is no better than the other, so there may be a personal preference on the part of the patient, personal preference on the part of the physician. And finally, don't forget that pediculosis pubis can be acquired during sexual activity. The treatment for it is outlined here. And that's it.